So again, this is a case study of planned study, which we've been working with Dr. Altis and his team on the idea actually for few years. For now, uh, submitted twice, I believe, didn't get funding, improved it, reacted to reviewers' um, feedback, and probably we improved it, or European reviewers are more, like it. So it went successfully through the stage one of UK's donor agencies, and currently submitted for stage two. We will know in October for sure whether it's funded or not. And this is hybrid two implementation plus effectiveness study proposal, which focuses on introducing evidence-based tobacco, alcohol, and substance use prevention in Georgian public schools. So let's go structurally. Problem statement. Georgia has one of the, not one, based on the available data, highest rates of injection drug use globally, hopefully going down based on last population size estimation, but still the highest. And uh, very high levels of alcohol consumption if compared to European adolescent uh, alcohol among school students. Okay, so and there is no system of primary prevention introduced in schools in this country. Various fragmented pilots, and that's it. Okay, implementation challenge based on our knowledge and pre-assessment data that we collected. Um, Adapting and implementing evidence-based intervention always might be challenging in resource-limited settings like Georgia. There are common variants specifically in this regard because it should be introduced into the public schools, so the teachers are overloaded, busy, maybe not willing to adopt innovation and new tasks. So this might be a barrier. But also Georgian policymakers, and this is just general, I guess for maybe in for other countries as well, you have the evidence-based practice like implemented in 100 countries, highly effective. You go to Georgian decision makers saying, okay, we have a problem, we need to introduce this highly effective intervention, and then universal response. Are you sure it will work in Georgia? Yes, of course. So they need local evidence in order to make decision to scale it up. Right now, it is implemented in 27 public schools of Georgia. The programs that we are going to scale up and adopt and also test the innovative element of it. So the goal of our study is to evaluate and compare effectiveness, cost effectiveness, and scalability of two delivery strategies of evidence-based intervention, unplugged. And those two delivery strategies are primary teacher delivery, and this is how originally this unplug was developed and implemented in every EU country and some low middle income countries. And we also developed innovative model of its delivery, online expert delivery, never been tested elsewhere. So we are going to test it first time here in Georgia. And we also want to generate the evidence to inform sustainable national scale up of unplugging Georgia, obviously. Why this is important? Again, high rates of drug use, high rates of alcohol use among Georgian adolescents, and the age 13, seventh grade is the best age to intervene with substance use prevention. Okay, and it's been tested in many studies. So the research address really existing urgent need in public health in Georgia, and findings can also be extremely useful for other countries, specifically if the online delivery by expert would show its effectiveness, cost effectiveness, and usability. Uh, to describe the intervention, it's unplug program, school-based curriculum based on life skills training, designed for 13 years old students and consists of 12 interactive sessions, role plays, uh, highly interactive, developing skills, not exclusively focusing on resistance to substance use, but life skills in general, with some focus on the substance, has been tested extensively in European setting, but also recently in low middle income in Latin America, Brazil, and few African countries, as much as I remember, right? It was Brazil and some Nigeria. Yes, thank you, thank you. So what we are going to do, and its efficacy relates to significant reduction in use of tobacco, alcohol, and illegal psychoactive substances, including cannabis. Uh, theory around it, we planning to use PRISM, practical robust implementation sustainability model, and REAIM is incorporated in PRISM, as you know. So REAIM, part of it helps to evaluate your outcomes. Why PRISM? Because we really believe that the environment and context in which this program will be introduced is important, and its specifics should be taken into account. And yeah, and the infrastructure and so on. So this is critical for understanding real world implementation. Elements of REAIM to be addressed, and implementation, and we will, yeah, examine elements of REAIM, evaluate implementation process across students, teachers, administrators, and policy makers, of course. Barriers so far that are known to us, actually I mentioned a couple of them: high teacher workload, low motivation, infrastructure, insufficient resources at schools, external environment, resistance of policymakers to take innovation without having a local proof for it. Some facilitators, there has been pilot study done by Jana Javahishvili back in 2012, so the AUDAP has been translated and tailored to local context, considering the cultural norms and so on, terminology, and has been piloted in number of public schools. Very well accepted. Teachers and students liked it. So we actually believe that we will need to further tailor it. We will have 1 year of formative stage, obviously, further polish, but in general, we expect that it will be a good, very well accepted and implemented. Selection of implementation strategies. Few of them, obviously, we might add others. Training and education. Teachers will go through 3-day intensive standard training. All implementers, actually, teachers and online experts. Online experts, there is a department within Ministry of Education, mostly composed of psychologists. They provide social support services to public schools, 120 professionals. So we are going to select 30 experts from this pool of 120 professionals, and they will be delivering online unplugged sessions in our intervention. Support and quality monitoring, fidelity checklists, of course, universal. Also, voluntary audit and feedback. We will be having regular meetings with teachers, and they will share their perspectives, perceptions, barriers, and so on. This will also help us to build the like peer support groups, you know, we hope so. And we also will be recording all the sessions. I mean, for online sessions, they will be recorded because it will be via Zoom automatically, but we are also planning to do recordings of in-class sessions, and then we plan to randomly check 10% of the sessions for the quality fidelity as attributes. It will be a lot of work because the study is huge. I will show in next slide. Incentives, we don't give monetary incentives. Our original proposal, actually, one of the arms were P4P, pay for performance. So we included monetary incentives for those teachers who would perform well with high fidelity. You now know what the fidelity is. But then we removed it. We received critiques that it is not sustainable and some other. So in current proposal, P4P has been removed, that we have incentives for participating in assessments. We also will provide pizza parties to classes every time they fill our forms, you know, during assessment. And we put some money to give to schools, participating schools on annual base, just giving to administration. And so they will spend it on whatever needs they have. I don't know, computer, internet, broken glass or whatever. Restructuring. So we will be testing this completely new form of delivery or online expert delivery strategy to overcome barriers related to teacher workload and stakeholder engagement. We will have community advisory board, central one, but also in all three cities where this will be implemented: Tbilisi, Kutaisi, Batumi. We also have Ministry of Education and National Center for Disease Control as supporters, not official partners, but they are very much supporting this project. Here I have this beautiful chart. For you to know, I mean, most of scientifically comprehensive ideas put in this proposal are proposed by Dr. Altis. Okay, so this is a teamwork, and this beautiful diagram is his invention. Okay, we just modified a bit terminology and numbers for the last proposal, but in general, it's large cluster randomized 3-arm study. Tbilisi, Kutaisi, Batumi, 75 public schools in total, more than 20,000 students, 7th grade students, huge sample. But how we end up with 20,000? This will be 3-wave trial. So in year 2, so year 1, preparatory, year 2, first wave. 75 schools are randomized in control, usual care, which is nothing, teacher delivery, online delivery, and then we train providers and they do this 12-week session. But next year, and we do our evaluations, but next year they do it again. And the next year they do it again. So 3 waves of the same intervention. So we will be able also to examine if the repeated delivery impacts on the clinical outcomes, like effectiveness outcomes, but also fidelity. Okay, so that's the interesting element of it. What else? Primary outcomes effectiveness, combined substance use, secondary nicotine, alcohol, drug use, process outcomes, rich adoption, implementation, dose, fidelity, acceptability, and cost. Yeah, we are going to examine the cost and cost effectiveness. Bristol University is partner in this project, so team which has been done a lot of national hepatitis C elimination program costing exercises. They will be helping us to do cost, Peter Wickerman's team, right? So they will be helping to do cost evaluation of this intervention. Conclusions, next steps, I don't think, I mean, yeah, we are expecting results, then we will work with policymakers to advocate for expansion, sustainability, and so on. But we also believe it will be really, really very useful for other countries. This online expert delivery, never tested. Let's see. I mean, how it goes. And this might be solution to a lot of barriers that usually are named where when we discuss this, introduction of any innovations into the schools and inserting something new in the school curricula. And I have here 4 questions. Just will indicate maybe, I don't know, we want to focus on them or not, just hints for the panel and for you, colleagues. So, what are the feasibility and potential reception of online expert delivery? What are your thoughts about it? How can we best ensure long-term sustainability and institutionalization? How should we work with decision makers? What are key considerations about fidelity monitoring and implementer support? I said we will have checklists, feedback audit, and random check of video recordings. Okay, should they work? Will they work? Anything else that we might add? Last one, considering this PRISM and REAIM framework, do you believe we will? Do you believe what will be the most critical to highlight for international audience from this implementation framework? Which aspects of the implementation framework? Okay, that's it from my side. თუ ციმციმებს უნდა დაელოდო და ისევ მიაჭირო, რაღაც უკავშირდება ხოლმე.
Very interesting presentation. I just have a comment about this online expert delivery, and you asked how potentially this can be sustainable. Have you thought of developing an application, like mobile application with all the content about the information, what you're planning to deliver online? And do you think it's going to work?
We did not think about it mostly because this is highly interactive.
Okay.
Intervention, role plays, and so on and so on. So it might be a lot of group work.
Okay.
So it might be really challenging or impossible even to develop a soft which will substitute.
Okay.
With the soft, it's not. Yeah.
Before Vincent's comments, one of the things that went into the decision around the online delivery, expert delivery, was there was a real debate. When you sort of look at the unplugged delivery, the fidelity was really a major driver of whether it worked or not. And the fidelity sort of suffered a lot because all the teachers got was a 3-day training session. And one of the things that had been sort of worked on here before even going here was they would get these experts, these psychologists who would go into these schools and doing it, and they thought they were getting pretty good results from that. So that was the sort of the experts in doing it. And then I think the COVID transformation, from a realistic perspective, you couldn't get a handful of experts to run into all these schools and do this. So was it the primary relationship with the teachers who just felt like it was too busy? I can't fit this into my time. It's one more thing, which is why the money thing came up a little bit earlier. But there was a fair amount of stakeholder assessment in terms of like what's going well, what's not going well, what might not fit before sort of coming up with some of these ideas. The money was a big issue.
Yeah, I was wondering how this intervention is similar to or different than like abstinence-based programs. I know those are very common. For example, in the US, like there is a very notorious abstinence-based program, and those are usually not considered very effective. So I was just wondering how this program integrates, for example, like harm reduction or other of those principles. No, no harm reduction. Okay.
This is
No,
evidence-based
12 sessions, only 2 mention psychoactive substances.
So that's a great work. Congratulations. I'd like to share the similar experience from my work of expertise. It's the immunization field. And WHO has developed this similar tool, Immune Patrol, which is about, in general, public health, but mostly about immunization. And it is quite successfully implemented for the long-term sustainability in Kosovo, in Armenia, in several different countries. But what mostly helped in the implementation process was that they established very close collaboration between Ministry of Health and Ministry of Education, and they implemented in a school curricula, like as a intracurricular activity. And they also trained the teachers of biology teachers, and they so it seems that they had dedicated approach to the specific teachers scope, right? And so far it works very well. It's very engaging, and now they are doing the effectiveness and impact study, and it's also very interesting how it worked. But for the long-term sustainability, definitely it's the coordination between these two decision makers and implementation into the curricula is basic.
Yes, thank you, because that's exactly what our focus was on. It should be in curricula, otherwise no sustainability. And yes, we have Ministry of Education, which actually in the letter of support named the department which we will need to engage when the study is funded, when the study is funded. And NCDC is part of Ministry of Health, and Department for Non-Communicable Disease is very much engaged